It is January the 19th. This is the first THCB gang of the year. I don't know how the hell it took us so long to get going. People have been busy at the start of the year. Bit of New Year's fun and games. I am Matthew Holt, at Baltimore on the Twitters, founder and publisher of THCB. And with me, I have Casey Quinlan from the Healthcare is Hilarious podcast, at Mike Magee on Twitters. Neptune, CEO of Suntra Modern Recovery, and also host of the Is It Serious podcast. And Mike Magee, medical historian, and Dr. Mike Magee is supposed to be here, but ain't here yet. So we'll try and figure out where the hell Mike is shortly. Anyway, all right. With that, being the cast and crew, there's some better version of them that you can see more clearly for those who are watching on the video. Time to, I think, have some fun and start going. All right. Well, it's only the two of us because we're wondering where the hell Mike is. But
well, I'm counting three.
Question one: how is everybody doing?
Well, I mean, so far 2023 is off to a good start for me. I can't complain. I'm still alive, and I'm out here, reading and doing a bit of writing and podcast production for me and for the folks that I do it for actual money. And I'm just sort of paying attention and making trouble where I see I could make some trouble and maybe do some good.
All right, we'll find out how much more of that. JL, what trouble are you getting yourself into in the first part of the year?
Well, I think one of my resolutions for 2023 was to stay out of trouble. So I've been trying to do that. Actually, you list my Twitter handle at the lead-in, but I actually canceled my Twitter account after 13 years on Twitter. I finally said, you know what? I think I've had enough. And, there's a reason I'm not on 4chan, and there's a reason I'm not on Twitter. So I took that. I archived all my tweets, so I have my tweet archive, but I am no longer at Jean-Luc Neptune. So all
right, well, I'll see if I can fiddle with that during the.
A number of people have made that decision, and I certainly see the why, and I'm still there, although I have created profiles on Mastodon and on Post.news, but I have never felt like I wanted to be any part of, brigading or whatever on Twitter. I use it for very specific purposes, and being part of the hashtag BCSM community for pretty much as long as I've been, around, or Twitter's been around. I mean, that community alone keeps me there, because particularly now that I've had a recurrence, I can ask questions and get valid answers from researchers, from MDs, from professional navigators, from patient peers who've been there, done that. And that to me is valuable enough that I have not pulled the plug, but I certainly am not a fan of the current owner. We'll just put it that way.
Sure. And one thing I will say also is that I think the current owner was the final catalyst for me. But I think, for many years since 2008, I have scrolled through Twitter for how many hours in search of news, political information, sports information. And I just realized at the beginning of the year or the end of the year, I was like, you know what, being plugged in all the time, this is maybe not the best thing for me. So
it's not, I think getting a little too scrolly can be deleterious to one's overall, mental health, or, whatever you want to call it. And I do not have a tab open to Twitter all the time. Yeah. And I go there specifically. I look at whatever it was I went over there to look for, and then I close the tab, done, moving on.
I wish I had your
bailed on
self-discipline.
I bailed on Facebook because for me, that was worse what they were doing, particularly to patient communities. I mean, the horse was already out of the barn and several zip codes over by the time I decided to do that. But it still felt like a positive move that I could take on my own behalf. That, right. Which it sounds like it's the same approach you took, Jean-Luc. It's like, this is an approach that I think I will get something out of. So go you.
And as Matthew said, my issue was self-discipline. I just couldn't control it. And as somebody who runs a company that treats people with addiction, I said, maybe I have a problem here. So I got rid of it. Now, I will say I'm on Reddit. I like Reddit, but Twitter is no longer part of my life.
I must admit, I've spent way more time on Reddit recently. I'm not sure it's replaced a lot of time I spent on Twitter. I have two problems with Twitter. One is the addiction and the fact that I think I'm very clever and therefore people should hear what I have to say, whether it's true or not, on a variety of topics, which is why I've always not. There are people in the certainly digital health and obviously various other spaces who are very good, who are always on message, never use their account for anything else, and I'm all over the place, some football, politics, general bullshit, whatever, and that probably puts people off. But the other thing that really concerns me, and I have no solution. This is the same issue, Casey, that you've been working on with the folks of the Light Collective, is that once you get that big community there, what the hell do you do? Because you can't move, right? And so if I think about historically, although it's kind of went away, the Health 2.0 thing grew a lot because they had a lot of big presence on Twitter when we were doing it. The healthcare blog itself has like 45,000 followers. I have like 30,000. If I go to Mastodon or Post and go back, now I'm back to 5 people. I mean, now it's back to writing my blog in 2003 with just my dad and me, reading it. But that's a thing. And, basically those of us who, everything that happens on, yes, THCB is independent and has its own website, which I pay for, and same as our, both of our podcasts that we work on, or 3 of us that we work on. The problem is when you're using these other channels, well, essentially for advertising, right? Advertising yourself, building your community and marketing yourself, it's kind of hard to figure out. Now, within the little health tech world, I've noticed that the health tech nerd Slack channel has grown dramatically. They're saying 3,000 to 4,000, 4,000 to 5,000.
That's not one I'm familiar with.
But I mean, but that's a very specific thing around digital health companies, right? It's not.
Right.
There probably are patient ones. Slack channels have their own problems. You still on somebody else's platform.
Yeah.
So I think
I'm a member of the digital
there is a
medicine
real
society.
problem with what's essentially a utility being given over to private hands, and if Musk decides he wants to do whatever crazy crap that he's doing, I don't know. It was pretty amusing though. Was it this year or later? It was this year that Greta Thunberg managed in one tweet to get that guy.
Oh my God, that Andrew Tate,
arrested.
that was hilarious.
He was allowed back on, and 2 days later he was in
like,
jail, which I thought was quite good.
Dear Andrew Tate, you are today's Twitter main character. Hang on your drawers, boy.
I'd never heard of this guy before. I'm pretty glad I hadn't. He sounds pretty horrendous. And then, with one tweet, Thunberg gets him arrested with this idiocy. And look, Mike has shown up. So we're back to
is arriving.
Apology.
No worries, Mike. When you get Mike, put your camera on. Here we go.
There he is.
go.
Hello,
Sorry.
Mike.
We were doubting you, but Mike Magee is now right.
Stuff happens.
This is stuff.
It's
I all of
okay.
a sudden realized what time it was. My apologies.
If I
okay.
spent my life apologizing for meetings I was late to, I would probably never get it. So
Good to see you.
We've talked about the start of the year. Let's pick up on a couple of things. I wanted to. I'll bring up something which I will get into later if we get a chance. I have spent the last end of the year dealing with insurance issues because, sadly, happily for her, good for our general life. My wife was actually laid off with a very nice severance package, but sadly ended at the end. She was laid off a while ago. And has decided that she wants to spend more time with the kids and isn't diving back into the workforce. When she figures out how little money I made this year, she may change her mind. But for now, that results being an American in dealing with health insurance. I've also had a lot of fun with this stuff the last few days, trying to figure out prescriptions and the change in the cost of prescriptions. So I can whine about that from a couple of different areas, but I was quite staggered about the fact that I am not as young as I once was, and health insurance on the exchange is quite an interesting deal. So I will dive into that. But before I dive into that later, on the healthcare side, rather than the personal side, what have you noticed in the last in the week or so since the turn of the year, JL?
Sure. So as you know, Matthew, I run a company where we help families and individuals who are dealing with addiction. And as part of the recent appropriations bill, the DEA, repealed the Data 2000 waiver. So the Data 2000 waiver refers to DATA, it's the Drug Addiction and Treatment Act of 2000, which allowed physicians to prescribe a medication called buprenorphine for people who were addicted to opioids, and essentially opened up the outpatient treatment of opioid addiction. What they did, though, the DEA did, is they created some pretty strong restrictions. Like there was a limit in terms of the number of patients you could treat. Initially, you could only treat 100, and maximum was 250 patients you could treat. You had to go through a pretty onerous training process, like 8 hours of online training. So I have the Data 2000 waiver, and the Biden administration and many other people realized that putting these constraints has actually made it more difficult for people to get treatment for addiction. So just recently, last week, I got a letter from the DEA saying that the waiver no longer applies. I can treat as many patients as I want. I don't need to get any kind of special training. And I think that's actually a very good thing in terms of opening up the treatment pathways for people who might be addicted to opioids, and allowing them to get treatment rather than from specialized providers, but like myself, to more general providers like their primary care doctor. So big
that's
news
good
that came out
news.
last week. Yeah.
That's good news.
I muted myself for strange reasons. Let me ask you a question about that, Joe, which is related, which is the issue around the Ryan Haight Act for controlled substances. Because one of the things I've personally run into is that as many people who follow me around know, both my kids live in Marin County, therefore they have ADHD. It's a requirement for living in Northern California, and they're both on medication. They both manage very well with that medication. Makes a big difference to their lives. One of them was diagnosed and prescribed and treated all the way through an online-only service called Brightline. And they are now, they have essentially kicked us off from the prescribing part of it. We can still use them for other services, because they think the Ryan Haight Act is going to be reinforced, which is the one which says you have to meet in person to prescribe controlled substances. Has that actually happened yet, or are they doing this, preventatively, as it were?
Sure. So I think it hasn't been decided yet. If I remember correctly, I think Ryan Haight required at least the first visit to be in person, right?
Yeah.
And during the pandemic, we waived that such that people could access medications virtually. But I do think we're going to, especially for controlled substances like the ADHD medicines, I think you're going to see maybe a move where you have to go and see at least a physician at least once in person. And look, I think the problem is Cerebral and Brightline and Dunn is the other one. They were, overnight becoming the biggest prescribers of ADHD meds. There's all kinds of stories about patients not being properly vetted. And, that's part of what the DEA needs to respond to, is the fact that there are players out there who may be overprescribing. And, how do you control that? How do you titrate, the level of prescription writing to the clinical need? And, I think that's it's funny. I wrote a LinkedIn post about the DEA. It was very interesting how negative most people were in their commentary about the DEA. And, for me, I'm a prescriber. The DEA is, neither here nor there for me. It's just another license. But I do think that the DEA has a really tough job. And in an environment where people do need these medications, but there's a lot of diversion, there's a lot of misuse, how do you manage that? And maybe the way it's going to get managed is going back to at least one in-person interaction or some other kind of control that they're going to impose.
Yeah, I actually could bring you in on this one, Casey, because part of the issue here is there's been a lot of fuss, and my major complaint of DA is that the part of it which deals with illegal drugs is a self-fulfilling, self-funding prophecy running the drug war. We did that completely wrong. You can argue about how we should have done it, but we certainly shouldn't have done it the way we were saying, let's make marijuana illegal and all other substances illegal, and therefore the DA can run roughshod over whatever they're doing. The part of the DA that deals with, but a big part of that part of the DA, the enforcement part, decided to go after doctors prescribing opiates. A lot, you can argue there's a lot of bad behavior there, but you can also argue a lot of patients got trampled in the process and some.
I will say my own experience as a stage 4 cancer patient under palliative care. There's a carve out both federally and in the state where I live, which is Virginia, where I am not supposed to draw the dragon glare. That my palliative care doctor is supposed to be able to prescribe for me what works. And what works for me is a low dose every 4 hours of oxy. And, I take that. I don't I am allowed, if I feel like I'm having breakthrough pain, to take another one in between the two, but we found the right dosage and the right cadence, and I'm okay. Other than days like today when stupid head goes to get what she thinks is going to be, an hour-long thing with a blood test and a visit. Okay, no, 4 hours because we're doing a transfusion. All right, fine. So I took a nap in an infusion chair. We're done. But I didn't have my my pain meds. So coming home was a little like, ouchie. I'm glad there were no witnesses, but got home, took the meds, put my feet up for a few minutes again, and I'm all good. So, getting to that point
is tough,
has
right?
it's been what, a year and a half of fighting on the one hand with my drug plan, my Part D under Medicare. Finally decided, you know what, I'm just going to throw these bozos overboard and just use GoodRx, which is that prescription price, low price thing. And because using that saves me money. But there's also the extended release, because I'm on an immediate release IR versus ER. The ER works even better than the immediate release does. And I could get away, when I say get away with, I mean, I was well managed taking 2 of the extended releases a day. But now I end up taking 4, sometimes 6, depending on, physical activity level and, whatever. But, trying to get the extended release, the pharmacy can't even get it. And if they could get it, even with GoodRx, it's something like $400 a month. It's nuts. So, as it is now, I pay somewhere between 50 and 60 bucks a month for the number of pills that they give me, which is, 100 and some. But it took a year and a half to battle through all of that. And meanwhile, they had me on morphine at one point. It just, there was just a lot of argy-bargy going on, which I keep really worrying about the people who aren't me or who don't have a me that they can tap in their family or their colleague circle to say, okay, well, here's how, let's work at this channel and see, let's try this, or, okay, well, let's try that. And then manage their lives, go to work, raise kids, find a job, do a job, I mean, I've been doing this one way or another since I managed my medical care, or my parents' medical care, back in, the late 90s into 2002 when they both died at the end of the year. But, that was a battle, and then it's only gotten worse. And luckily, neither of my folks were on anything particularly, crunchy when it comes to DEA oversight, et cetera. But, my dad had Parkinson's and my mother had just the long-term effects of taking corticosteroids because of a pituitary adenoma that was surgically removed, but then she was on like Synthroid and corticosteroids and, et cetera, for the rest of her life, which turned out to be 23 years. And so she was, both my folks ended up goofy because of medication, but, luckily they had us, the kids, particularly me, to, help out. But it's just, it's a full-time job. It's crazy.
That's the bit I want to get into is that there is not, you have all these demands, and you have chronic pain patients for whom some things are the only things that work. And frequently, the doctors they're getting from have been closed down. There was a recent case in a doctor in Los Angeles getting closed down. A bunch of his patients committed suicide.
Yes.
And so,
Yes.
and it seems to me there's been very little interesting in caring about, for those patients who for whom this is, perhaps the alternative.
Life or death.
For life or death, right?
It's like I can either function or lie here like a lump.
This to me has been, consistently that hasn't been dealt with. Now, I understand that while it's been going on, we've had a massive opioid epidemic. However, opioid use is now back below where it was in 2016. So, and the other thing that's happened is that meanwhile, the more you restrict access to opiates, the more you see a bump up in use of street drugs, and particularly now, also we have fentanyl on the street drugs, which is causing a lot of causing a lot more trouble. So I go back and forth about this. But just to go back to the ADHD ones for a second, it seems to me that what we saw during the pandemic is two things. One is massive increase in mental health issues amongst kids, particularly.
Absolutely.
Issues, right? So, not a surprise that my daughter's, symptoms massively escalated during the pandemic, and also my son and my daughters. So there's a lot more demand out there. And it said that adult ADHD also is massively undertreated.
Sure.
So, I agree that, you can argue that Cerebral wasn't doing this with the best intentions, et cetera, et cetera. But I'm still confused. I'm a bit concerned if we say, oh, it's all done. We just had overprescribing. We're going to slam the door on it, and we're going to make people go back to try to find people who prescribe the stuff, because it's going to be tough. So I'm very glad they did what they did with substance abuse, but to some extent, JL, that's the curative, not the curative part, but that's the reformative part for substance use disorder treatment, as opposed to how do you deal with things like pain, different types of mental health issues. So I think this is, we're going to find a lot more coming out of this.
It's important, though, I think, Matthew, to complete the circle here and acknowledge the fact that, we're one of only 2 countries in the world to allow direct-to-consumer advertising. So, the fact that we are over-promoting and pushing drugs and then have to deal with the consequences of DEA trying to do their job because we've over-pushed them, or that you got the Sackler family conspiring with a wide range of institutions to abuse the meds that you may need, or any of us may need. We've kind of created this dystopian system.
So, Mike, I'd like just get on that, because, number one, you were responsible for one of the very first big consumer advertised TV drugs. And I've seen a couple of things lately. One was I didn't catch the whole study, but I saw a headline flash by that a lot of the most advertised drugs are not that effective. And the other thing that's clearly true is that there was another.
Which makes sense, by the way.
There was another headline studying STAT, which was about people complaining about online drug ads. And I'm kind of with them. I was watching, I don't watch a lot of baseball, but the time the Giants and the Dodgers were playing in that playoff game a couple of years ago, my kid was 6. And they were explaining to me what erectile dysfunction is. I don't really want to explain to a 6-year-old what that. I have to explain to him why this thing is coming on in the middle of a baseball game. And there's a lot of, I know you've come to that.
These kind of, these smart reforms that you would expect to happen naturally, right? Just recognizing there is no other country like ours that does it this way. So we must be doing something wrong, right?
But more and more of them
but this has been going on now for over a century. Way before there was ever any television, we couldn't get needed DEA type reforms because the newspaper industry's major advertisers were the purveyors of these various different cures and chemicals. And so, we've been living with this for well over a century. And all I'm saying is, you can't complain too much if you are not vocally after eliminating this kind of overpromotion, because we created the problem that you're now complaining about.
And Matthew, my podcast partner, Mark Lewis, and I did a whole episode actually about drug advertisements. I think that was our first episode, actually.
One of the early ones, yeah, sure.
Yeah.
I think what you pointed out, what struck me, I think, and I think you pointed out a little bit in that show, is that, when it started, this was Claritin and Viagra and stuff, which you think have effect, I'm looking at Mike for the Viagra one. You didn't actually write the commercials, but you were somewhere in the mix there, right? And then
I'm guilty of having written commercials.
It was Lipitor, it was even some of the,
but not drug commercials.
It was even some of the depression meds. That stuff's all generic now. So although they're not cheap and giving it away, no one's advertising that stuff. What's getting advertised now is stuff that it boggles my mind. There are enough people who care about the whatever weird thing for, whatever strange sub part of the of Hodgkin's, non-Hodgkin's lymphoma or whatever it is that must be very small numbers of people those ads are trying to reach.
And Matthew, I mean, I will tell you, I have seen many ads recently where I've had to look up the indication, like what is this drug treating? And, sometimes, pharma companies create their own diseases, but some of these diseases are quite rare if they are legitimate diseases. And I think the model, and I'm interested in what Dr. Mike has to say about this. I think, what we've moved to a world is, let's say a Lipitor pill before was, let's say $100 as a reference point. I don't know if that's the right number. I think these drugs that are being marketed now are niche indications, but they're like $10,000, $100,000 plus indications, and it makes sense to advertise.
Yeah, I mean, the drug, the original drug, the first line treatment that I got for my stage 4 hormone positive breast cancer was $14,000 a month. It was the list price. And it's like, what? I mean, I did not pay that, nor did Medicare, because I know how the game is played. But it's just like, what the hell are you even thinking? So, and who is paying that? Or is that just like an open for the negotiation, for the horse trade, whatever? It's just crazy.
Well, I think it's like a college tuition, right? There is somebody out there who might pay $14,000, the full sticker price, but there is a very aggressive process of negotiation that happens across all the different ways that a payer can pay for the medication, and it's an infinitely long sliding scale with 14,000 at the top.
Yeah.
Well, as John Luke said, sometimes the conditions get invented for the drug. The very first direct-to-consumer TV ad was in 1957, and it was a full 12 minutes explaining a new condition called ataraxia. And it was only 6 weeks after that ran that Pfizer released its new drug Atarax to treat ataraxia.
What the hell was it supposed to be?
I mean, the Sacklers, Arthur Sackler's really claim to fame. And the reason why he's in the Medical Marketing Hall of Fame is because he was able to simultaneously promote to 2 different companies, Librium and Valium, and presented them as if they were for different things. One was for nervous tension and the other was for relaxation, so
something else.
There's all sorts of shenanigans, but I'm just saying the U.S. Over a long period of time has taken this to absolutely absurd levels, and for practitioners as well as for government regulatory agencies, it creates an enormous problem.
Right, and I think also, Matthew, the really key thing here too is not only do we have this unique practice of direct-to-consumer marketing, which is a multi-billion-dollar business, but you also have a laissez-faire approach to regulation, right? So, during the opioid epidemic, it's not a surprise to anybody that these drugs were being overprescribed, right? It wasn't a surprise to anybody that small towns in West Virginia were getting shipped 1,000 times the volume of medication that would conceivably service that community, so I think there's a lot of laissez-faire. We're not going to try to regulate. We're going to appreciate the free hand of the market, and it's only when it gets so bad after 20 years that the DEA says we have to crack down. And unfortunately, because we didn't manage it effectively, there's a very heavy-handed approach to stop this problem, and I think that's why where we are.
Yeah. I mean, the increase in milligram dosage too, particularly with Oxy, was just like, I don't know who amongst us saw Dope Sick, that limited series that Michael Keaton was in about this very topic, about the Sacklers, and it was here in Virginia, also Kentucky, Tennessee, and West Virginia. But I mean, it's everywhere now. But it got kicked off there, and it still is pretty bad. But it just, I don't understand why there's such a resistance to regulation on this stuff, because, it seems as though the medical industrial complex will always default toward how much can we get people to pay for that versus, is this even something that works or is worth doing? And that's everything from, pills, patches, procedures, whatever. Not everyone, in fact, very few people are, statistically literate enough to be able to go out and well, my doctor said that I have X and that I should take Y drug for it. and, go out and find the study or studies that support that potential new drug that they are taking for this thing that they might have. And it's just, the only practitioner who has ever recommended something to me, who not in the cancer zone, this is, sort of general sort of family medicine, general practice, was I went to my eye doctor just to, get my eyes checked. You do, particularly when I was getting into the geezer zone. I think this was when I was in my late 50s. But I went and, gave me the eye exam, whatever, and said that since it looked like I had the beginnings of macular degeneration, that I should consider taking this drug that was, and he handed me a copy of the study. And I was like, does he know me? have we met? And, I looked at it and it made sense. And I will say that it's now I think it's 7 years later, the process of macular degeneration happening in my eyeballs has been arrested. So, I'm good. I'm just going to keep taking this because it seems to be working, and being able to see where I'm going, it's an important thing in my life. I would not want to give that up.
That is, to me, the one thing here is that, yes, there's a lot of chaos in the way things come on the market. There seems to be a lot of, there's heavy hands, and there's lack of regulation, there's heavy hands. There's been a lot of thought about who actually needs what. And I don't know what the answer is. For things like the mental health crisis and things like the pain crisis, which are there and are real, in people's lives. I don't know what the answer is here. I'm pretty sure the answer is not whatever the hell we're doing right now, but maybe I'm wrong. We'll see. All right, I wanted to move on. I wanted to bring up one thing, which just to tell you all I've been through this, because it's something that many of us don't think about. I don't know how we're all getting what we're getting. But as I said earlier on, I had to go into the process of looking at the exchange for California. My wife's company I'm still allowed to buy Cobra for another year. And it turns out that it's about $1,800 a month, or just over 20 grand a year, for my family to have insurance on the Cobra plan with a $4,500 deductible. So the price went up a little bit this year. That's almost not too bad by modern standards, right? And it's quite rich insurance. And the interesting
imagine making $60,000 a year and confronting that.
This is where, the good news is that in California, at least, and the expansion states, they bumped the number if you're making, $20, $30, $40, $50,000 a year, you're almost certainly qualifying for Medicaid.
Yeah. And
everything's free. Now, there's another question as to whether Medicaid, the insurance is free, but you can't get to a doctor is another question. And Ian Morrison, who himself has just had his own quadruple bypass, is doing
right. Yeah.
He'll be on in future gangs in the next couple of weeks. We can look at his chest and
we can ask him penetrating questions.
Exactly. But he just went down to McAllen, Texas, where they have a different approach to Medicaid, but the Medicare.
Yeah, that was the one that was in
Gawande's thing. Things have moved on a bit, but he was at a hospital which there was actually making money off Medicare and was managing to piece together state programs to pay for people who would have been on Medicaid in California. But for somebody who hope, fingers crossed, makes a bit more than that. Yes, this is a big chunk of change that we're now going to have to be paying. But so I went to the exchange to look and see, okay, what is the what on the cover California could I buy instead? And there are a lot of complexities, not the least of which is that you forget that if you go to the exchange, once you hit a certain age, and this year I will be hitting that big number, will be turning over, and I'll be 5 years away from Medicare. I'm now a pretty damn expensive person on the exchange, right? So my family insurance actually was, because it's based on age, was way higher than I would have thought it was going to be. And even with the subsidy for somebody who, and then by the way, I have to guess how much money I make this year, which I never know a year in advance. So it's horribly confusing. You have to guess that. And then you can theoretically, if you make too much, let's say a particularly good year or whatever.
Yeah, you get drop kicked.
I might have to pay the subsidy back. And the unsubsidized rate for an equivalent plan was more like $3,500. The subsidized rate was a little bit lower, depending on how much I said I was going to make this year. And, well, my family's going to make, who knows, my wife might decide to go back to work. So you're in this situation where I was really struggling to figure out what the best plan was for me to buy, or whether to stay on Cobra, which is what I did. And the other thing that's quite interesting is that I happen to be a patient at the world's most expensive primary care group, One Medical. And I've talked before and written before about how they and UCSF, who they're related to, seem to get paid a tremendous amount more for the same services than others do. I actually literally had that experience because just before Christmas, I had an injection in my back for the back issues I've been having. And I had 2 telehealth visits on 2 days because I didn't know whether I'd be able to get one, all that complexity of getting one. And the 2 telehealth visits, one was with a UCSF anesthesiologist, one with a pain doc, and one was with a private pain doc. And literally, Blue Cross of Massachusetts via Blue Shield paid the UCSF doc 3 times the amount they paid the private doc. So there's this wacky disparity in pricing. And for that reason, I think, I don't know whether UCSF is in or out of the Blue Shield and the Blue Cross plans on the exchange, but One Medical is not in them. You can't get it because One Medical is equally expensive. You can't get to them. So then I'm faced with the other equation, which is, okay, it may be a little bit of a savings, but then I have to tell my wife and my kids they're changing their doctors. And then it's like, oh, I don't really want to do that. So I was put through this process, and being who I am, I should be in pretty good shape to be able to make this decision. I talked to one of the companies I advise, who makes a tool for choosing between us, and it's a very hard decision to make as to if you have this kind of choice between a expensive Cobra plan and the exchange plan. But yeah, the exchange plan is, even though there are now quite generous subsidies, they're not giving it away. It's still pretty expensive. And yes, you're supposed to not spend more than, I think it's 7.5% of your income on a silver plan or something like that. But nonetheless, these numbers are all, pretty fuzzy. And it's hard to work out, especially as we're still in a situation where, if you're not on a regular, salary where you have a regular income, which many of us are not, and more not these days, and you don't know exactly what you're going to earn, you have to guess about the subsidy. So I was going through this whole thing. I was comparing it to my time in France, right, when I fell off and broke my rib and went to the doctor and paid cash. And then if you're French, you get paid back 80% or 70% of what you pay out. And you just pay for it in tax and a tiny little bit of Social Security. And going, okay, Obamacare has improved dramatically the experience for people who didn't have insurance before. And yes, it's much, much better than what we had before. But compared to anywhere else in the world, it's still dreadful.
Yeah.
Expensive. So that's my little editorial about what I ended up. In the end, I kept the Cobra plan without the subsidy because I thought it wasn't.
Yeah, this is one of the things that breaks my heart about watching what's happening with the NHS in your mother country, Matthew.
Yeah.
That it's heartbreaking. Well, because it was like a crown jewel, and between that we've had the same problem here in the US, but with us we've always had it. We never tried anything else. And the thing that kills me is that we exported this mindset about how everybody should have an ROI on and we need to make more money. Yes, we do need to pay for things. I'm not saying healthcare should be free. I'm not crazy. But at the same time, defunding the social safety net simply so you can point to it and say, it doesn't work. We have to stop doing this. It's like you did this for that very reason. And if you just would admit it, I'd have more respect for you. I would still know that you were a robbing thief, but at least you're admitting it. But no one admits that. But between Reagan and Thatcher, that's what's happened. 40 and 50 years later,
it actually got worse, right? Because in the UK, if you look, there's actually a great article in the Economist about the little that left-wing rag, The Economist, a few weeks back, which was showing exactly at what point did spending start getting cut to the NHS. And I think the UK has had the double whammy, which was it elected a Conservative, didn't actually elected a coalition government in 2010 after the crash, right? We had Republicans in power, and so we got Obama. They had the Labour Party in power, and so after the 2009 crash, they elected a Conservative government, which did this austerity program, trying to balance the budget during a recession, which really hurt a lot of the programs that happened. And that was done off the backs of the the social safety net built up by the Labour government in the 2000s, which had been very successful.
Yep.
And then since then they've run into this Brexit trauma, which has really struck the economy and done. Yeah, it's a totally self-inflicted wound.
Yeah.
And and now they're at the point now where they've lost the people working there are now all on strike, and there's chaos, and I don't know how they're going to get it back. The one thing that is different between obviously the British system and most of the other Europeans and the Japanese and for that matter the Taiwanese is that yes, the rest of it is government spending, but because it kind of flows into a semi-privatized system anyway, albeit highly regulated, and it kind of has kind of a fee for service backing, a bit where the Canadian one does for most of the time, and the way the French does, and to some extent the Germans. It's a little harder for those other countries to sort of starve the system the way that has done in the UK. And so you don't, I mean, they have, yes, everybody has their problems, but the way it's bubbling up in the UK at the moment is particularly, I think is particularly bad. And it's come down to the fact that, that for a bunch of unconnected political reasons, you can't, the country's economy and the country's government has gone the way it's gone. And if you look at the French and the Germans and a bunch of other people, they're not having this level of problems. They do spend a little bit more, right? I mean, the UK got up from 6% of GDP to 9% under the Labour government, and it's kind of retrenched a little bit since. Whereas the French, the Germans, are also spending sort of 10 to 12. Nobody's spending 19 or 20% of GDP the way we are, right? I mean, that's but then again, nobody has the drug prices we have, or the executive jets from the private equity funds that we have running healthcare.
Oh yeah, private equity. Don't press my buttons.
Yeah.
Don't press.
Okay,
my buttons.
Casey, I'm not letting you go on that because we only have 18 minutes left, and I know you'll take the rest of the time.
But Matthew, just to jump in quickly, right? I mean, you talked about the difficulty of making the decision as an individual, right? Think about it from an employer standpoint. So, I employ people get their health insurance through me. I went through an open enrollment process recently where I was presented with 40 different Aetna plans. And now I have to sit there and try to figure out, okay, what patterns do I need to offer based on the types of employees? How much can I afford to spend as a company? How much can my employees spend from the standpoint of out-of-pocket maxes? I mean, I saw Aetna plans that had out-of-pocket maxes that were $10,000 and $20,000 for individual and family, right? How many people have even $1,000 in their bank account? So it's not just a challenging thing on an individual basis, but employers are dealing with this at the same time that inflation is going up and costs are going up. It is a very challenging environment to purchase any type of healthcare product, health insurance product, whether you're an individual or an employer.
I agree. I actually, so, Casey closely is this part. I ran for one of the companies I'm advising, I actually helped them with this exact thing. So I also ran an opening, and it was kind of rolling over last year, and they only had one. They bought it through Gusto, which is kind of the ubiquitous payroll service now. I only really had one choice. It gave them plans. It was like a silver, bronze, gold of but what was interesting is that I think I mentioned I do advise a company which has a tool for it's called Health Lucid, that has a tool for selecting between plans, and they go into the minutiae of how much, what age are you and your family, if you're an employed person, what are you likely to spend on healthcare this year, and they spit out the equation. Are you better off going over there and taking the HSA option, the high deductible health plan, and getting an HSA contribution from your company, or you're better over there staying on the richer plan? And I wasn't able to make that. Gusto makes it very hard for someone to make that equation. But I had the same issue. It wasn't the level of choice I had, but I did introduce the fact that I suggested to the company, and the company did it, that they made a little bit of a contribution to an HSA fund to suggest that the people who were thinking they were going to be pretty healthy and were taking the richest option should actually go into the high deductible plan, because they get a bribe and they probably get away with it, and they probably wouldn't spend the deductible if they were like a single guy age 28 or whatever. And that saves the company quite a bit of money, right? It was saving the company probably a $1,000 a month for each person who chose to go one with the other. So there's all kinds of, and Jen Baines isn't on this week, there's all kinds of stuff going backwards and forwards. And this has been an environment with JL, as you know, which for the last decade has been a pretty healthy environment to be an employee and not such a good one to be an employer, right? You've been paying up. Lots of very profitable tech companies have been layering it on with the infertility treatments and the massages at work and the this and the that and all the, the growth of all these digital health companies, selling into these companies has been for like an extra thing. And if we go into, and who knows the consequences, if we go into a recession and things start getting, bleaker, employees get tougher, you can see this is going to get nasty again. And we're at nasty at a case, when it was last nasty, which was 2009-10, I think at that point, family premiums were at about, 15, 16,000. Now they're about 25, 30. I mean, it's like, it's a big,
I don't think we're going in the right direction.
Nothing has been going in the right direction. So I'm with you.
And Matthew, just to give you a data point, the family plan that I get through Aetna is about 2,000. I think it's 2,100 a month, and went up 15% from last year, if you can imagine. Wow. And that's just on premium, right? That doesn't include sort of the back end increases that you get in terms of increased co-pays, co-insurance and things like that. So, it's as you said, if as the economy tanks, this is going to be very challenging, in terms of offering health insurance.
But let's say one thing. I was whining about this compared to other countries and the rest of it. If you look at a company, I don't want to compare us with the UK because we're never going to get to a completely, socialized system, even if they're moving away from one. But if you look at this compared to Germany or France, something like that, the complexity that you're visiting on employers and employees and everyone, because we don't have one settled system and people move around so much and people move in and out of Medicaid. About a third of Americans now are in Medicaid, and about a third of many states are in like big states like California. Something like 55% of births nationally, I think, in our Medicaid. I mean, there's a lot going on here, and the complexity of this is never going to go away. And I haven't even introduced. We're at minute 47 of the podcast of the video podcast. Have not even introduced the concept of Medicare Advantage versus traditional Medicare.
Yeah.
We won't even go there today. I know.
Yeah, that's
it turns out that complexity is quite profitable. So
absolutely.
I think, all of this is quite purposeful. And the more complicated it is, the more different options you offer, the more expensive it is at the end of the day. It's not a value. And in fact, for the patient and for the doctors and nurses who are trying to function, it makes it more complicated. The other thing is that the sociologists now, looking at the various different countries and so forth, are attaching stability of the democratic process to the actual functioning of their healthcare systems, and found that the worse the delivery system, the more unstable and more autocratic the countries ultimately become. And I think we're beginning to feel that here because, you got a lot of unprocessed fear and worry that the pandemic kind of reinforced, and that directly affects trust in your government. And then you get upheavals and Trumpists and all these other crazy ideas. If you can't trust, you're really in rough shape when it comes to trying to run an effective government.
So, Mike, I thought you were about to tell me that now we had a new House of Representatives, this stuff was all going to be solved.
Yeah, for sure.
Yeah, they're already playing, deficit, debt ceiling games.
This is amazing.
Today.
I mean, the fact that I have no idea, having seen what happened during the Obama years, why the Democrats didn't. I mean, maybe they couldn't have mentioned in cinema, but why the Democrats didn't say we'll just get rid of this debt ceiling nonsense. No other country in the world has this. It's that we play with.
Well, as Jean-Luc suggested, and as both of you guys said with your own particular cases, this kind of complexity and overselling of things that aren't necessarily beneficial, it just exhausts the provider, because the provider is doing their best to stabilize their patients. Their patients are confused. They don't know who the hell to trust. And the worry becomes kind of rampant. So it creates, I think, a huge system. I've always felt that eventually we'd cry uncle. We'd get to a fifth of the GNP dedicated to this thing, or we get to patients being so upset, or doctors and nurses saying, I can't do this anymore. And we would say, okay, we're going to simplify it. We're going to make it universal, and we're going to see, what we can do with this thing. But it just hasn't happened. I don't know. At this point, I'm hitting 75 tomorrow. And
Happy birthday tomorrow.
Happy birthday tomorrow.
I just don't see it around the corner, the kind of change that we
I don't either.
No, I'll give you one tiny example of like ruining the life. This whole thing, basically ruining the life. So now we're back to the meds. My daughter needs the refill. This is a controlled substance for ADHD. I mean, they do fine with it. We're not using it to start a meth lab in the backyard, but whatever. It's all going fine. And I get it through a delivery service called Alto Pharmacy, which is very nice. Works very well. They deliver to our door, so I don't have to go and queue up every month, right, in CVS for two separate kids. Which is, I guess, twice a month. And it's a long queue, as you know, in CVS or whatever.
Yep.
The issue, but the pricing, I'll be writing this up later. The pricing seems to have gone haywire. I don't know if they got changed. The PBM got changed it's the same plan, as I meant since I stayed on the same plan. But what was a $25 allowed amount, to which I either pay a $10 copay or the full amount depending on what's deductible, has now gone to either $75 with insurance or $55 without. And I'm going, so they want to sell to me the cash price for cheaper. There's an insurance price, which is more. And I have been haggling back and forth with the poor person on the other end of the customer service chat line, message line, email line at Alto Pharmacy. And there's probably a gazillion people having to deal with this kind of question as to what happened. I'm about to have to call the health plan and ask them what they're going on. But don't forget, it gets worse. Because if I decide, well, this is silly, I should do the GoodRx thing, the variation in cost for GoodRx of this med between different pharmacies is massive. I mean, it's $25 at Rite Aid and up to $150 elsewhere.
Yep. And
every time you want to switch one of these controlled substances, you don't get a prescription you can walk around with. Everything's electronic anyway. It's sent from the doctor to the pharmacy. The pharmacies can't move it to another pharmacy as controlled. So the poor doctor, either the psychiatrist at Broadline or will have to be dealing with me. And I'm going to call them up and say, can you move it to this other place? Because it's going to save me $50 this month or whatever. I mean, even for something as small as this, trying to understand the price and the complexity of it is kind of beyond me. It's kind of beyond the customer service person. I'm going backwards and forwards with it. I actually put a whole list in one of my healthcare tech groups to see if someone could help figure it out for me. But that's a microcosm of the complexity we're putting on the system. And all of this is just mate work, right? They couldn't say, we agree nationally that this generic product is X dollars and your share is either covered in your thing or you're paying 10% of it or whatever. And the simplicity we would get if we get there, like, is, which would be so, I mean, I've spent 3 hours on this already. On this pathetic little thing, and I'm with you. I'm with you, though. I don't see how we get there, because this, we're all sitting around saying this would be ridiculously complex, but there seems to be, we did Obamacare, which was the best we could get with 60 Democratic senators, and there seems to be no interest on revisiting this stuff. I don't know.
And Matthew,
I think the healthcare lobby.
Casey, sorry, jail.
And Matthew, I mean, I was so one of the things I like doing on Reddit more than I liked on Twitter was sort of getting into it, getting into debates and getting into philosophy with people. And I think somebody, I can't remember, it was a Reddit post about, Medicare or something, and just so many uninformed people who were just saying that, government healthcare is bad and this and that. And again, it becomes at some point to tell the difference, like, are you trolls? Are you just stupid or what? And what I said is, like, listen, I ran a medical clinic for 3 years. And I can tell you right now, Medicare and Medicare Plus supplement is like the easiest, most straightforward thing you could ever handle as a provider of healthcare services. And patients love those plans. My mother is on traditional Medicare Part B. She's got a supplement, and it is the easiest thing in the world to use. So as we think about all this complexity, right? I mean, a typical physician practice is probably spending 15 to 20% of revenue on revenue cycle management, right? I sort of loved the Medicare patients back in the day because it was so easy to manage them. And remember, we were doing physical therapy, so that required a whole series of steps that maybe a traditional provider doesn't have to get into. And it was still a lot easier than interacting with a major commercial insurer like United or Cigna or Aetna. So I don't know. As I was saying in this Reddit group, I was like, if you guys only knew how easy it was as a patient and as a provider to be on Medicare, you might think differently. And then, of course, I get the people saying, keep your government hands off my Medicare. And I said, okay, I think now it's time to go away.
Yeah.
I mean, it's worth. I'll come to you in a second, Casey. It's worth
because it escaped. Whatever it was, it's gone.
It's worth knowing one of the cleverest. We haven't talked about. Somehow we haven't talked about the hottest thing in tech this year, which is AI and ChatGPT and all this stuff. One of the cleverest tools I run into the last couple of years is a company called Infinitus, which built a really super clever voice bot. And the job of the voice bot is to call the insurance company on behalf of the provider, sit on hold for 35 minutes, get some poor human at Humana or United or whatever, who's got a PDF manual they're looking at as to what is it that is required for pre-authorization, what kind of things do they have to send them to get whatever the thing is approved for pre-auth, And I said to the person running the company, I said, why don't you just have your API go to their API? I said, because the insurers haven't got an API. They've got PDFs. They haven't PDFs that, you have to go to page 17 and go, for this disease and this drug, it's this 5 things we need to check off there. And this is still going on. And what these guys have done is automated the phone call part of it. So it comes back and says, yes, we recorded them using the cleverness of voice transcription. We figured out it's these 6 things we need to send them. And then hopefully you'll get the pre-auth. But I'm going that is something that we've brought up with because we don't have any national standardized plan about what we're offering and who's going to pay for it. And we just let it get into chaos. And it's got to the level of complexity, as Mike said, yes, it's profitable, but it's craziness. So I don't see an easy way out of it for any time soon. I do know that we're going to continue to play with it, and every time, I'm getting to the age and I have kids and family now where I'm touching it more and more. It's just the more and more
it's a full-time job.
Absolutely.
Just managing your family's medical care. It's a full-time job. And it makes me glad, Jean-Luc, to hear you as a provider say that, Medicare with a good supplement is the provider's favorite. Because when I was rounding the clubhouse turn in that last year before I turned 65, I sought some advice from some of my age peers in the e-patient leader zone. And uniformly, they all said the same thing: hire a broker and avoid Medicare Advantage. It was like, oh, okay, fine. So I went out and I did that. And I have been, I knock wood and am grateful every day, because that was still a few years before, the cancer troll decided to come back and move in, bastard. But, I'm very grateful that, my karma worked out on that one.
We will have George Halverson, who continues to write on THCB, and just sending another article about why this is completely wrong and why Medicare plans are much better. So Medicare Advantage plans are much better, and that debate's going to continue on a bit. Although there's some interesting stuff back and forth on that, and what works and what doesn't work, and that's going to continue to run. But again, we're now 50-50 in the Medicare program between the two. All right, we are right up against time here. I want to quickly go around and say, okay, what are we looking at next? What do you think is going to be the thing that we're going to be talking about in a week, 2 weeks, 4 weeks? Start with you, Mike.
This week I got approached by a bigwig in DC who was part of a group. They're putting together yet another coalition, and this one focused on getting credibility back for scientific information. They basically were concerned that trust in science information had plummeted, and that misinformation was everywhere and they wanted to respond to it. What I found interesting in the proposal was the fact that they seem to be blind to the fact that most people consider science providers of the kind that are represented in this coalition or proposed coalition to be elite. And that fundamental to the presence of growing mistrust in science is the fact that the general public believes that it is sourced by elite individuals who are profiting off of science that can't be trusted. So I went back to them and basically said, you got to understand that if you're going to be forming a coalition in support of good science, you have to have foundational principles and commitment to the establishment of a healthful democracy. You know, you can't just pull it out of nowhere that what we need is good science and it'll make America healthy. You need a functioning democracy that delivers scientific information and practicing as a basis for health, as part of health, but not the same as health. So anyhow, I was just surprised that there was this blind spot that continued to exist after everything that we've been through, but it's there.
Well, you've made that job even harder. Well done. I'm pointing out the obvious. Casey.
Well, I'm going to keep an eye on this, the debt ceiling argy-bargy that appears as though it will be ongoing for a while now. And sort of the tea leaves for what to expect for the next 2 years. It's not going to be pretty, I can say that. And also keeping an eye on, how private equity is impacting the healthcare zone. Not as though that was a surprise to me. I've known about that for a long time. But those are the two things that I'm looking at right now. And also just trying to stay alive. So here's another day where I woke up, so I'm good.
Good. Well, I, as you've all noticed, I'm invited to a bunch more of these in the future, so no excuses.
I will be showing up.
There we go. JL.
I've just been, I'm interested in M&A activity in the digital health space, and I've been looking at CVS and their on again and off again potential acquisition of Oak Street. So Oak Street, as you may remember, a primary care provider powered by technology, sort of competitor to One Medical. It seemed like the acquisition was certain about a week ago, and then there's been some additional information that said it may not happen. But I think it's very interesting to see CVS moving into the provision of healthcare services outside of their clinics and thinking more broadly about it. I guess it's not even digital health anymore; it's health services, big time healthcare services, and I'm interested to see where that goes.
Yeah, I'm speaking of somebody who bought a few Oak Street shares way up from the rumored acquisition price. I'm wondering about this. maybe getting out while the getting's good and taking my lumps as the answer. All right. Well, that is the end of the THCB gang for today. I want to thank my colleagues who've been on today, and they were. We'll get this screen up. Mike Magee from the Wilds of Connecticut, Casey Quinlan from the capital of the Confederacy. I keep saying that, but I know it's not true. Richmond, Virginia, and John Neptune from the island of Manhattan, the spaceship landing on Earth, island of Manhattan. Looking forward to. We will be back for THCB Gang next week. I have another bright gang for you. I'm Matthew Holt, THCB founder and publisher. Thanks a lot for spending a bit of time with us, whether you're watching live or listening on the podcast.